Hello, everybody. I'd like to welcome you to our Bioengineering, Joint Bioengineering Seminar Series. So I would like to introduce you to our today's speaker, Dr. Mahmoud Mirhusseini, who is actually a cardiothoracic surgeon and holds a professorship at in Behesht University in Iran, as well as he is clinical assistant professor of cardiothoracic surgery in MCW here in Milwaukee. Dr. Mirhusseini is an author on over 300 publications, and he is a member of many boards and associations, professional. And today's presentation is called Revascularization of the Heart by Laser. And I have to share with you a small secret that a few days ago we tried to set up the all this presentation and make sure that everything works. And I happened to see some very fascinating videos. They actually, there is some material from the surgical procedures, so I would suggest you to finish your pizzas quickly. Just wanted to give you a heads up, if you are not tolerant to any kind of material like that, you can close your eyes or check your phone or something else, but I have to mention that beforehand. But with no further ado, I would like you to all join me welcoming Dr. Mirhusseini.
Thank you for introduction. Today, I would like to take you to a journey of research that was in the background of this work that is presented to you. And I have to mention that I was the first heart surgeon that trained at Marquette University at that time, now at Medical College, Wisconsin. Dr. Lepley was my chief, and together we went down to St. Luke's Hospital because the county was not supporting the heart surgery program in Milwaukee. And then we developed the program at St. Luke's Hospital, which is now one of the nation's largest heart programs. One of the things that I want to bring to your attention, the cooperation between engineers and medical field. Unfortunately, this cooperation is very weak. In the past, doctors, nurses, they run into problems with technology, and they ask the engineers to do something about it or make something too helpful. And engineers have no knowledge of medicine, and so the doctors don't have knowledge of engineering. And this lack of cooperation really has hurt patients on the long term. It is the mother of science. I have to tell you, this is saying the mother of science is mathematics. No matter what branch of science or even biology, it ends up with some formulas in math or physics, things like that. This is the belief that I have had over the years. This is the second time I'm appearing before a group of engineers or students of engineering to give a talk. The first one I was invited by SPIE, which is the largest organization of engineers of the United States, and they were nice enough to invite me to give a talk, more or less on the same subject, and this is the second time. I have to bring to your attention the lack of observation, both in engineering as well as medicine. I have to show you these slides. It shows that what I'm going to talk about, revascularization of the heart by laser, that means bringing new blood supply to the heart muscle. and is based on physics and also biology, as well as tissue response to laser energy. And it's very important to keep in mind. I'm not a laser specialist, but I have done lots of work in the research laboratory, hundreds and thousands pieces and animals, experiments, before we brought this technique to approval by FDA, which is, as you know, is a big animal sitting in Washington and holds all the things in check. And we have to convince that this is not dangerous. They are very cautious after thalidomide, which was a pill, sleeping pill they were giving to the pregnant women, and then the baby came out without arms, legs, and this kind of stuff. So they're very cautious until something develops to bring it to clinical application. Now, about observation. This caricature cartoon is 1,000 years old, believe it or not. This was drawn by Avicenna, Ibn Sina, who was a physician, and in Europe called him for centuries because his text was taught anatomy, physiology, as a prince of physicians. If the physician needed a prince, he was the one, sort of. At that time, he discovered the circulation of the blood. He called them veins varid, means the term varid, the dark blood, and then sheryan, which is red blood. And the center of the universe, of course, was the heart sitting on the top. That's his drawing. It's not very nice cartoon, but this is 1,000 years old, and he's writing right there. This is taken from a textbook of Canon. Incidentally, when his text went to Europe, there were two textbooks. One was Canon, one Teb. Teb means medicine. The cover of these two books changed. Canon is in law, became medical field, and the Teb is in law. It's a reverse type of cover of the two books, because people, they didn't know how to read it, because it was written in Persian or Arabic, whatever. So he observed these things. 150 years ago, a guy by the name of Harvey in England suddenly rediscovered the circulation. Oh, we have a heart, we have a circulation, we have these veins. The heart pumps blood into the body, is the red blood that brings nourishment and goes back to the heart, and then varids or veins. And this was a rediscovery almost 1,800 years later. This was because of lack of observation. Okay. Look at this leaf. This is purpose, some of the biology I've read, or things like that. On purpose, I put this leaf. This is one of the organization of factories that God, whoever, has created. Is a fantastic organization. One of the things had never paid attention to this. People working in fluid dynamics, osmosis, fluid dynamics. Coronary bypass surgery, which, as we know, we have coronaries, we get to that, was developed by René Favaloro, who was a friend of mine, in the Cleveland Clinic. For the last 30, 40 years, they have been done anastomosis of the vessels, the coronaries, and presenting this as the beautiful thing that helps the patients. Patients with angina, heart problem. Coronary artery is one of diseases that, coronaries, which is the worst disease and cause of death in the United States and probably worldwide. One of the things that anastomosis of these two vessels were completely forgotten how it works, recently was discovered by two engineers from Southeast Asia. They wrote a paper that the doctors, physicians, surgeons, especially cardiac surgeons, they are very illiterate. They have never paid attention to the thing a plumber A plumber comes to your house, fixes the pipes. They know for years, for centuries, that when you connect one tube to another, has to be in 45 to 50 degrees. That the leaf shows this. Every leaf, you know, at the vein of the leaf, it shows 45, 50 degrees. Why? Because the fluid in the body, as well as the veins in the plant, works in laminar flow. You are familiar with laminar flow. The speed of the flow in the middle is higher than the one near the wall. And the blood particles usually stick to the wall as they flow. But if your degree of anastomosis is more than 50 degrees, it causes turbulence on the flow. And if it reaches 90 degrees, some of the laminar flow reverses. Actually, instead of going, the pipe is open, but reverses, some of it go backward if it's 90 degrees. This was overlooked for almost 40 years. So the observation of this something similar or simple thing is so important. Now let's go talk to the essential things that we were going to work. Doesn't go forward. Well, use that one. Okay. One of the observations was done in 1964, that done by two investigators. One was Dr. Sen, one Vinny Gopal from University of Delhi. That the heart that we have in mammals, that we are in that group, actually the circulation of the heart is different from reptiles. This is the circulation of the reptile like a snake. The top of that muscle, you see, is compact. And the rest of it is arborization of channels in the heart muscle. This is the design of the reptile heart. Later on, I will show you, we go through this process when we are 14 weeks, 12 weeks, 14 weeks gestation inside our mother. But slowly we lose these channels and our coronaries develop. The coronary supplies to our heart. There are two coronaries, right and left. And then they bring the blood supply to our heart. But in reptiles, the coronary is very minuscule. If you ligate the coronaries on a reptile, nothing happens, no infarctus, no damage to the heart muscle, because the blood comes through these channels from within the heart itself. There's a Persian poem said, this is the heart is full of blood now, and we don't take advantage of it. He said, if I translate this poem is, we're running around the world looking for our beloved. The beloved is sitting in the house. We run around the world thirsty with parched lips. The jug is full of water next door. So the heart is full of blood, but does not take advantage. It has to go blood out of the heart through the coronaries, come above the aortic valve, and then come back to the heart. But this coronary flow of blood is about 200 cc per minute total. The heart weighs about 200 to 300 if it's normal, even in athletics. So it takes advantage of lots of oxygen. The heart is actually in depth, means deficiency in oxygen at birth, at normal heart when it beats. Is our heart pump, or motor I call it, efficient or not? How many of you think the heart is an efficient pump? Is it efficient or not efficient? As far as the motor, kilogram per minute per meter, whatever, E. The heart is very efficient. How efficient is your car? It's only 3 to 4% maximum. The gas guzzlers is about 2% efficiency. The amount of oxygen you burn and the fuel you burn is only 2-3%. Your heart is 25 to 30%. It's the marvel of engineering as far as efficiency as a motor. So, unfortunately, as with good living, lack of exercise, diet, all that stuff, this coronary slowly closed down, and patient get infarction, and I'll show you some pictures later, symptomatic, and the patient either dies or become crippled with chest pains and heart failure. So what about if we could make artificial channels to the heart muscle, so replace these coronaries? The idea came by Dr. Sen and Dr. Gopal from University of Delhi in 1964, and I read that paper. This was the journey. I won't take you through it. They tried to use this with needle puncture, like acupuncture, so-called. And it's successful. They thought it's good. Animal could be ligated, those coronaries. They did dogs and pigs. But this channel, they did not stay open. And they closed, the animal dies or get infarct, massive infarct. This was the back of my mind. I was just observing. I read this paper in 1964, published in the Journal of Annals of Thoracic Surgery. In 1968, I was still resident at Marquette. I was preparing for a specialty examination to become a cardiothoracic surgeon. I had to go get the exam. And I heard one of the examiners, he's very astute, and checked lots of questions about the trachea and oropharynx and during examination. So I read the journals of ear, nose, throat, which now is one of the areas laser application is very common. I read an article that there's a group in Boston University Hospital. There was a soprano, a beautiful singer, and had a nodule on the vocal cord, and they treated this, evaporated this nodule with the laser. This is the first time I heard about laser, 1968. And I told myself, what a good thing. And there was no scarring, no damage. It came to my mind, is it possible we use that equipment, whatever it is, to make these channels that Sten did that in 64 and keep that open for the coronary artery disease? So we went to work. This was an observation and took a long, long time. Okay. I'm not expert in the laser. I'm not a physicist, but I did experiment lots on the tissue with the laser, all kinds of lasers. First of all, I called Boston University Hospital to see, where did you get this gadget? They told me there is a scientist, physicist, they developed this for the clinical or medical field because the laser was discovered and made, the first laser, I show you a picture later, by Ted Mayman when he was working at the Bell Laboratory and TRW. So, make the story short, I found out the chief scientist, his name was Dr. Polanyi, working for American Optical Company. We flew, my wife and I, my wife's a nurse, we flew down there, visited him, and told him that our idea. Polanyi had the back, he came originally from Prague, and his uncle's name is in the book of Einstein. He was one of the contemporaries of Einstein as a physicist. His offspring was very intelligent. He said, yeah, we have this gadget, and we are now using ear, nose, throat, and some cutaneous thing. Make the story short, This is a summary of people that work on the laser until Maiman developed the first operating laser. This is the first laser in the world that's made by Ted Maiman. It was a piece of ruby, a flashlight, a strobe light, and a mirror, which was painted with the gold to reflection. Because gold mirrors, you can do it almost to 99% reflection, and there's no other things can do like that. So he made this in the Bell Laboratory, and was the first operating laser in the world. And I got this picture from him before he died. He died 2 years ago. He became a good friend. And at the end of his life, he was working in British Columbia. I'd moved from Los Angeles to British Columbia. He was fed up with politics here. Anyhow, this is the summary of people who work in laser and medicine and the thing. And so the experimental thing, one of the things very outstanding work on the laser on the human being was done by Dr. Zwink, who helped people with diabetic retinopathy. You know, diabetic, they get ruptured blood vessels, the body, and retina, the bottom of their eye, and they get blind. So he used argon laser, the first time in the world, that blocked up or coagulated that leaky blood vessel, and many other contributed. Dermatology, Dr. Goldman from University of Cincinnati. And these last two people, Bredemeyer, a physicist, which made articulated arm for the CO2 laser, and Polanyi himself, which got the manipulator. Now, medical lasers, there's a variety of lasers we eventually got hold of. The guys that helped us was Dr. Polanyi himself on the board of American Optical, and then the Department of Defense. I come to that very shortly. And you see the variety of beam, how we can manipulate the pulse, cavity damping, various other things that you... This is the first operating laser for medicine. They call it telephone booth. It looks like a telephone booth. I don't know if you have seen this before or not, but it has a hand manipulator, handpiece, articulated arm through the mirrors. We can transmit the CO2 laser with that to the target of the blood, to the area we were working. This is me and Dr. Polanyi and me, which are the honor to get to know him. And this is the handpiece that they made laboriously with lots of work to not to lose the power when they get to the end of the arm. Laser tissue interaction, we started to see this, how this laser works on the heart muscle. And we did lots of work. Initial work, I was in Wausau, Wisconsin, at St. Mary's Hospital. Dr. Lepley sent me over there to start a heart program for them, which I did. And over there, we had a laboratory, and we got all kinds of lasers from all over. One of the guys helped me a lot, late Merler, the Secretary of Defense. I visited many laboratories around the world under the Department of Defense contract. I made trips to Israel twice, and various type of lasers. We worked on tissues, on material like graphite, and we came eventually to some conclusion. So what does the laser do in the tissue? Some of it penetrates, some of it absorbs. It has a thermal power which could burn, and also has kinetic energy. And another thing that it has is a magnetic field around the beam of laser when it's powerful. So we were looking for select a laser that does not burn the tissue, evaporates the tissue, but not burning the tissue. Because any kind of injury in the tissue you do, the body defense pours in cells, material there to inflammation, we call it, and then consequently closes that channel. And that's how the body heals. If it's a thermal effect, that's what is going to happen. But suppose we have a laser is powered enough and is absorbed by water, the white water, because this is the effect of laser summarized on the tissue. Incident laser come, backscattering, tissue penetration, transmission, etc., etc. The heart muscle, and this is the mode of the laser. This is the mode we used, double aught. And the profile of the beam of laser, usually we call it Gaussian mode. The center of this has the highest power that lies over here. And as you go to the periphery, like an inverted bear, the power decreases. So we need lots of power in this area. Now how? This is not power alone. I get to that. These are the effects of tissue. I don't want to take too much time going through pulse laser versus non-pulse laser, how is the tissues penetrated, how much it absorbs. We came to the conclusion that the best laser for heart tissue is CO2 laser. Number one, we can get it enough power. Number two, when we expose the heart of the animals, it causes arrhythmias because the impact of laser to the heart muscle causes irregular heartbeat. So we gauge the laser exposure to EKG of the animal at the PR interval, is the PQ or ST. At PR interval is a window, small window, few milliseconds. And if you laser expose the animal heart to that level, the upstroke to R is a diastolic field of the heart. It means the heart is full of blood. Now why? Because the laser beam could travel damaged inside the heart or go through the heart. So, but if the CO2 laser arrives in the unidiastole, no matter how much power you have, absorbed by water and doesn't travel anymore. This is the thing we found out through the experience. So we chose the CO2 laser for revascularization of the heart. And these are the profiles of the beam. I don't want to belabor you for all this. But what are the thermal effects of the laser? Supposedly it's too much time it takes, the exposure. Cause tissue edema, that's the one. Vessel shrinking, protein denaturation, and eventually burning. Any one of you in the audience know how much temperature you need to coagulate the white part of the egg, albumin? Any guess? You have had egg Benedict many times. How much temperature centigrade coagulates that albumin of the egg? Any guess?
20 degrees.
How much?
Maybe 20.
81?
No, how long?
No. How many temperature?
Right, but how long does it have to be applied?
We don't put time here. We just, temperature rises, okay. With what level coagulates, the albumin is a 60 degrees centigrade. Okay, so we have a laser, we have to have a laser which does not cook, does evaporate the tissue. The theory of Einstein that the light mostly acts like a particle. Electromagnetic field, you've heard of that? But the particle theory of light. Suppose you have a bowling alley and the pins are there and the ball is coming, knock out these pins. Okay? A powerful laser with short pulse duration, such as several milliseconds only, knocks out the tissue, evaporates that, and does not burn. And that's what we discovered slowly over the experience. We need a powerful laser. Okay, what did we get it? It is the profile of many lasers, as I said, we checked. The CO2 laser, KTP laser, XML laser, and the CO2 is the one absorbed by water very well. And this is the profile of absorption with different wavelengths. I don't want to go through that too much time. Okay. And this is the thing we talked about. Here is the thing I wanted to tell you, to show you. This is the heart of a patient. Has this configuration, compact, non-compact. This is not a reptile heart. This is a human heart. Where is he from? It's from, unfortunately, from Milwaukee that died. Okay? This is a specimen. And we have lots of genetic things right around Milwaukee area, as a matter of fact. They call it compact, non-compact heart failure. WHO, World Health Organization, has not been able to classify it into the cardiac failure classification. This is an evolutionary type of heart failure, which could be helped by this laser. Now, why? Because we have this when we are small baby, a tiny fetus inside mother. This thing does not develop to become compact and coronaries develop. The life expectancy of this unfortunate patient is only 40 to 45 years because a heart muscle cannot take the load of circulation over a long time, 70, 80, 90 years old, and they go to heart failure, and the only treatment we have is heart transplant. So in a human being, we have this. This is a genetic thing that's fortunately not very many. How this is discovered recently, I have to add, because of echocardiography. Echocardiography shows this very clearly. I have some picture, I believe, and we'll show that. But anyhow, going back, we discovered that CO2 high-power laser is the one to use. This is schematic, the thing. I summarized what I said. Coronary arteries, they're terminal branches. They close, we get infarction. Infarction is extensive, the patient dies. If he doesn't die, it causes scar and heart failure. Reptile heart, coronaries, I already described it. So if you have this coronaries problem, we could make this channel with the laser from external to the cavity. The blood comes like artesian type of well, perfuses the heart muscle, and the patient recovers. The patient pain goes away, and gets out of heart failure. This is the animal experiment. This is, I thought to show you one of these. See, this is laser channel. This is the animal, which we call the pat, dog. This is the date. There were 2-3 months later, we did the autopsy, and here's the channels of the laser is open. The laser channels in the heart experiments, we did a powerful laser, devoid of pycnosis and scarring, and they stay open. We injected India ink, and they go through these channels. It shows perfusion of the heart muscle. This is Dr. Mayman with his wife, Kathleen, that developed the first laser. This is the baby that we strive, and we got it from the United States Defense Department. This is the length of a tube, 8 feet long tube. So you couldn't bring it to the operating room. Diameter about 12 centimeter. And we gauged this to a handpiece that Dr. Polanyi had made, and Dr. Bredemeyer together. And we brought it to his table, and we had all this recording thing. These are preliminary laboratory that we have. This was at the basement of St. Mary's Hospital, Warsaw. And we did all the animal experiment there, and then at the basement of the building at the VA hospital here. We convinced ourselves that this is the route to go. We need a powerful laser, CO2 laser, to do the clinical trial. our animal survival, our findings, everything was submitted to the FDA. This was a journey of life, I guess. And they sat on it about 3-4 years. When I went to Moscow and presented this work as experimental, that the animals, we had animals, dogs, 2 years running around on the farm without coronaries, all living on these channels. They're convinced that they should do the trial on the patients. They will publish a journal of Soviet Journal of Cardiovascular Surgery that we are set up based on the technique this guy from the United States has proposing, and we're going to do some of these patients. They have no other choice. They have lots of pain. We have done bypass, they closed. We have no other choice. We're going to try. And then that helped us a lot. We gave this paper to the FDA and they said, okay, we did all the work, but the human work is going to be done by the Russians. And that competition helped us. They gave us permission first. Do 2 patients. If they don't die, we give you more permission. So we did 2 patients at St. Luke's. Then nobody died. No explosion happened. Head patient went home 2, 3, 4 days later. Then they gave us 12 patients permission. We did 12 patients. The subject of these patients was published and took the attention of lots of people, companies to make the laser, because such a laser you could not bring it to the, first of all, they took it back from us, the original laser. So the companies, they got interested to make laser for the heart revascularization. And at this time, the FDA set up a center for restudy. The center of restudy be independent, not to be part of us or anybody, multi-center studies. The part to review it would be Cedars-Sinai Hospital in Los Angeles. All the data of the patient would go that we find. They go there to evaluate, and then we could do the surgery on the patient and then submit all the findings to that center and to the FDA. This way, how it worked out. One of the things that helped us a lot was the University of Minnesota. Dr. Wilkie, a radiologist, was working for Siemens company with a group from Netherlands, working for a new MRI, with a high-power MRI for developing software for Siemens. So we took some of our dogs over there to the University of Minnesota. At that day I was there, Dr. DeBakey, famous Dr. DeBakey, was visiting. He asked me, what are you up to? I had seen him before here as a visiting professor. I told him, I says, good, keep up the good work. So this helped us. And the people, the scientists at the University of Minnesota and from Netherlands helped us to study some of these patients. This picture was developed by help from General Electric, because these patients that we found out that the thing they have made in the market, which we could not bring the big laser to the operating room, we had about 200-watt laser. We didn't think that is enough to do without stopping the heart. So the patients that needed the laser revascularization, bypass surgery, we combined the two. The area needed bypass, we did the bypass. The area we could not do the bypass, we did the laser channel. This patient, as you see, these clips over there, these are the parts of the bypass surgery. And this is the areas. Remember, this is the time still digital arteriography was not, these are analog. The digital arteriography was not developed yet by the Siemens or GE. And these are the channels you could see that the laser channels perfuse. We have the movies of this, that once you inject the dye inside, this is a patient. Once you inject the dye here, you see goes through these channels and goes through the heart muscle. So this proved that the technique is viable, working, providing the patient goes on bypass and the temperature brought down. Because the amount of power we had on the laser, commercial laser now, not that the big baby, but it was not enough to do on the beating heart. Okay? And this was the thing that we have, and many, many other things. Okay. The indications, what are the indications for this technique? Patients, they have no bypass surgery, can't do bypass surgery, or you can do one area of bypass, not everything, then you combine the two procedures. Patient should not have the laser surgery, or this patient have left main heart disease, that is the main truncated problem. Ejection fraction of the heart is very low. In other words, anesthetic, you're putting them to sleep, they might not make it anyhow. They have to be above 20%. Anybody know what ejection fraction is here in the room? Ejection fraction is the fraction of the pumping the heart, say 60 cc goes out per beat or 80 cc, okay, minus during diastole. Diastole minus systole, divide by diastole, multiply by 100. So because the fraction amount of the heart puts out of that 80 cc, it should be about 50 to 60%. So every time our ejection fraction of a heart, which is by damage or infarct or virus infection, goes down, so we are closer to the problem. And when it reaches 20% or low, the patient is in heart failure. This is the ejection fraction I thought to discuss it. So they have to have good ejection fraction and go. Complete revascularization is possible by bypass plus laser, or sometimes laser alone if you have enough powerful laser. After this thing, we were invited to Russia again to present this to Academy of Science over there. Dr. Chazov was the head of the chief cardiologist there, and I was invited, my wife part of the team, we were invited 10 different countries, and then to help them to develop some of areas of the heart surgery. And then on the road back to the airport, we had accident. I still have a rod in my left leg. But anyhow, the guy was working with us in the laboratory, and all the data, they sold it to a company and made money. And they put the machine on the market. And this is that machine, they call it heart laser. The machine puts out, this laser, CO2 laser, puts out about maybe 400, 500, 600 watts. It's inadequate for using it for alone. With the bypass surgery together, cool the heart is good. But it's used now worldwide, this machine. And that's the story of it. But some of our patients that we did it, they were under extensive study. How much time we have left? 5 minutes? Yeah. This outcome of this thing, that extensive studies were done both by us, University of Minnesota, and Cedars-Sinai. This shows with the stress with the patient, they had the laser surgery. It shows this the MRI with the magnetic resonance, seen a time volume curve. One is ischemic, one is laser done. It's improvement in the time volume curve of this patient. I thought to show you this. And then the patient's categories. Make the story short, there are the patients that worldwide is being used, this machine now, but is inadequate for pulse alone. Unfortunately, is good as a combination. And I stop here and show you a clip of how we do it when we don't do the bypass on this machine, and show how these channels look like on this unit. Could we show you that? Everybody left? Let's show the clip then, because we don't have much time left. So it has become a part of the parcel of the taking care of patients with coronary artery disease. This is my assistant speaking.
A double lumen endotracheal tube is not necessary. The pericardium is opened and retracted with stay sutures. The heart exposed and the cardiac anatomy defined. The laser handpiece is brought into position and fired. Penetration is confirmed by echo. The laser is armed at the surgeon's request when the target area is selected. When the foot switch is depressed to fire the laser, the EKG is analyzed and energy delivered at the peak of the R wave. The laser is disarmed until the next target area is selected. Jets of blood squirt from the channel immediately following delivery of laser energy. Gentle finger tamponade stops the spurting blood, which subsides completely within 1 to 3 minutes of gentle pressure. The procedure is repeated until the desired number of channels is obtained and all ischemic areas are revascularized. Bubbles are caused by vaporization of tissue and are quickly absorbed by the blood in the ventricular cavity. Following laser revascularization, the heart and adjacent areas are inspected. If there is no bleeding, the pericardium is closed loosely, one chest tube inserted, the wound is closed in layers, and the patient is transferred.
This is a brief summary of the thing. I want to show you one other thing yet, if I may, again, this, that'd be interested. Maybe just that's the last slide I would, after these, before that, go back.
Back or forward?
Yeah. Oh. Okay, well, this is the channel of a laser on a patient. Then 6 years ago, 6 years before his death, he died of cancer of the lung. And we did an autopsy on the patient. What did we find? All the laser channels were open. Not only that, the laser channels are endothelialized. You know, endothelium is one of the lining of the cells that all our blood vessels are covered. There's a very fascinating of tissues or cells which secretes material like heparin, prevent the clotting and regeneration. And this lining is a true endothelium. How is true? Because we did the DNA with the immunoperoxidase studies on this layer. The laser channels properly done, they stay open at least 6.5 years on human, and they're endothelialized. Thank you very much. Any question I could answer?
Questions?
Yes.
Why? I'm just amazed that you could create these new paths for the blood to flow, and the patient wouldn't bleed out. I mean, it would clot up quickly enough, or how would it?
Yeah, that's a good question. The laser channels, blood comes to it, okay? And then also micro vessels, they're open up like artesian well. You know, crisscrossing small vessels that have been cut off and they're bleeding sort of. The laser channel has more force of blood and goes through that channel. The top exposed to air, the blood clots. The top of the area clots, but the remaining channel stays open.
Wow.
Because the force of myocardium, you know, you could have about 140 millimeter mercury pressure inside the channel. That's right, because inside the ventricle, how do you get hypertension? Where does the hypertension come from? One is the force of the heart, one is contraction of the vessel. Here's the force of the heart, if it's normal, near normal, could generate between 140, 160 millimeter mercury pressure. And inside the channel, maybe because the size of it is small, maybe less pressure, but still overwhelmed the little channels, the side channels, that they are cut off and they did not have blood inside. You see, the heart itself, its muscle, one of the things that's fascinating about the heart, the muscle. First of all, the heart muscle is different from other muscles. It is classified as a smooth, sometimes as a striated muscle, two groups of muscles, okay? But the heart actually is one cell, because all these cells are connected. And not only that, there's a subject of another discussion. They share nucleus. The cells share, for example, once a cell had this nucleus, the nucleus could be shared by three other cells. So they share the nucleus of the, that's the only place in the body is like that. This is one aspect. Another thing is about the heart is law of tout or none, ran, as the French. That means all or none. Have you heard of that? All or none. The electricity when we use to pace the heart, or the heart pace itself, when it reaches this amount of millivolts, the heart contracts. You increase the millivolt, the contraction does not get better. So this is threshold, all or none, because of all the cells are connected and they're contractile, and then the force of them are coordinated. That's the only place in the body is like that the cells share nucleus with the next cell and the next cell and the next cell. So the left ventricle actually could be considered one cell with multiple nucleus. This is the design of the heart muscle. And 80% of the heart muscle is water, because crevices have blood, and then the tissues are full of water. But in spite of that, the heart is thirsty, because when the coronary circulates to the heart, the veins bring it back by way of coronary sinus to the right atrium. The saturation of all your veins is 70, 80, 85%, but the coronary sinus, 50%, because the heart has sucked out all the oxygen could from amount of blood could supply by coronary. So actually, the heart naturally is an oxygen death. And that is really fascinating part of the structure of the heart and how it functions. And again, I have to tell you, the design of heart pumps and stuff like that needs cooperation between engineers and doctors and biologists, and not I just ask the engineer, well, make a pump for me. That's what the guy did in Pennsylvania, the first heart lung machine by Gibbon. Gibbon told the engineer of the hospital, we want to, he was really competition between him and Dr. Lillehei in the University of Minnesota. The first open heart surgery was done by Lillehei. How did he do it? He hooked a baby to the mother. That's what he opened his heart and repaired the heart. When he was doing that, the administrator of the hospital ran to Dr. The chief of overall chief the department, and he said, there is a crazy guy in the hospital who wants to kill two people. People who go under major surgery, they kill one, he wants to kill two. He said, what's going on? He said, he attached mother to a baby. Fortunately, it worked all right. He repaired the defect inside the baby's heart by using the heart of the mother who was put to sleep, vein and arteries connected to the baby, and he could stop the heart, repair the heart, and close it up. That's how open heart started. And then Gibbon asked the engineer to do that. What was the first heart pump came from? Just guess. From dairy product. Pumping the Amish, they were pumping the milk to the tanks for distribution. And there was the Siemens, forgot the name, but anyhow, was working with the finger. This finger presses a tube, then this one and this one and this one, and then propels the milk out into the tank of or container distribute the milk around the town in Pennsylvania. So they used that, and the 3 minutes or 5 minutes after the patient was on this, the blood turned out like a syrup, the urine. All the cells of blood of patient destroyed. That's the first pump was done. Because they never knew how the heart and inside the vessel work, how the thing worked. And then there's a mechanical thing produced without consultation between engineer and the doctor is very nonsense, really. So the cooperation between you guys and the doctors is essential if you're doing anything good. Thank you.